All right, so again, we're going to talk about peptic ulcer disease, also known as PUD. You'll see it abbreviated as PUD as we move through the slides. Lots of objectives, but they're very similar objectives to what we have dealt with before. What causes peptic ulcer disease? What can we do to prevent peptic ulcer disease or relieve symptoms? What medications can interfere with testing for H. pylori, determining an appropriate treatment regimen if they have H. pylori, if they have NSAID-induced ulcer, if they have a bleeding ulcer. All right. And so thinking about the side effects that are associated with those treatments. So if you can answer all these objectives, you will be good to go for the exam. So thinking about the stomach and the normal gastric physiology, we have several parts of the stomach. We have the fundus, we have the body here, the pyloric antrum, the pyloric canal, and the pylorus, which is a sphincter that opens and closes and dumps the stomach contents into the duodenum or the small intestines. We have the esophagus here, where the food comes into the stomach. We have a sphincter here, the lower esophageal sphincter, again, that keeps acid into the stomach and preventing it from coming up. When it does come up, when the acid is allowed to come up to the esophagus, what's that called?
GERD.
GERD. GERD, great. You remember something from last semester, all right? And then we have the cardia here. So there's 4 sections of the stomach that we talked about: the fundus, the body, the cardia, and the pylorus, right? The cardia is the area where the contents in the esophagus dump into the stomach. The fundus is the upper part of the stomach, and then followed by the central region or the body. And then finally, the pylorus is the lower section. And the pylorus is the area that facilitates movement of stomach contents into the duodenum. There are 4 different types of cells found throughout the layers of the gastric glands. The first is the foveolar cells. Those produce mucus. Next are the parietal cells. Those produce hydrochloric acid. Then we have chief cells, which produce pepsinogen, and we have G cells that produce gastrin. That should be a little bit of review for you. I think Dr. Hong talked about that when we were talking about GERD. So this should be a little bit of a review for you. So peptic ulcer disease, what is peptic ulcer disease? It's painful sores or ulcers in the lining of the stomach, in the first part of the small intestines, of the duodenum. So this is what a healthy stomach looks like. Nice, looks like sand dunes maybe inside of there, right? Nice, smooth inner lining of the stomach. When we have peptic ulcer disease, we have stomach ulcers inside the stomach, or we can have a duodenal ulcer here, which is at the start of the small intestines. How do you think people feel with these ulcers in their stomach or in their duodenum?
They can have fever, extreme pain, nausea, vomiting, those types of symptoms.
Yeah, so it can be anywhere from like a gnawing pain to a sharp pain. I don't know that we necessarily see fever unless there's some kind of secondary infection going on with it, but definitely pain, discomfort, depending on how bad the ulcer is and how deep the ulcer is. Right, great. A lot of times patients can be asymptomatic. They might not even know that they have an ulcer. This is especially pertinent for elderly patients. They might not even know they have an ulcer. But most of the time we're going to see dyspepsia, or that gastric pain in the middle or upper stomach. We can see GERD symptoms like belching, bloating, cramping, heartburn, nausea. early satiety, which means that they're eating and they're feeling full really fast. If the ulcers go untreated or are not found soon enough, the ulcers can lead to perforation. So we end up getting a hole in the stomach. We can get penetration and fistulization. So we start getting tracts to where they're not supposed to go. As a pharmacist, the number one complication that we're concerned about is bleeding. All right. And then we can get gastric outlet obstruction as well.
Dr. Hall,
Yes.
I have a question.
Yes.
Since uh this can be asymptomatic, does there like prophylactic not prophylactic, but is there a certain recommendation for elderly patients to get I forget the name, but when you insert a tube in the esophagus and go to the stomach and see I forget the name of that procedure, an endoscopy. So
Uh, yeah. So since endoscopy is invasive, a lot of times we will treat the patient with PPIs for 2 weeks. And if their symptoms have not improved or come back raging after the 2 weeks, then we refer them for an endoscopy. So this is why GERD treatment is you can only self-treat with over-the-counter for GERD for 2 weeks, because if the patient's needing the medicine beyond 2 weeks, they need to be evaluated for peptic ulcer disease. So that's kind of the progression. As you come in, you say, I'm having these stomach pains, these stomach issues. They're like, oh, it's GERD. They pop you on a PPI for a couple of weeks, and they say, if it doesn't get better in 2 weeks, see your doctor for further evaluation. And then that further evaluation leads to the diagnosis of that endoscopy. That is the gold standard. And so we stick a camera down your throat to look in the esophagus and look into the stomach for ulcers. All right. If we have an endoscopy and we see an ulcer in the stomach or the duodenum, the patient should be tested for H. pylori, because H. pylori is one of the number one risk factors or number one causes of peptic ulcer disease. So we do want to make sure we're checking for that. So how does peptic ulcer disease occur? We're going to talk about H. pylori today. That is a bacteria. I know y'all thought you were done with ID, but here it comes popping up over and over again in this module. It's because there's so many bacteria in the GI tract and it's so easy for them to translocate. So H. pylori is one of the number one causes of peptic ulcer disease. NSAIDs also put patients at high risk for peptic ulcer disease. Cigarette smoking can increase your risk of peptic ulcer disease. The treatment for that is smoking cessation. And that is pretty straightforward, although challenging for patients to do even when we give them medicines. Psychological stress and physiological stress can lead to the peptic ulcer disease. And this is going to be especially important when we talk about stress ulcer prophylaxis later on today. And then there can be dietary factors. What is something that somebody can consume that you would think that could lead to peptic ulcer disease?
alcohol.
Yeah, alcohol being a major risk factor for peptic ulcer disease. Right. So in the stomach, we have protective factors like bicarbonate, mucosal regeneration, and prostaglandins and mucus, and these are all the protective factors. Our protective factors are constantly up against our damaging factors like pepsin, gastric acid, NSAIDs, H. pylori. And when our protective factors get overwhelmed by our damaging factors, that's when we get ulcers. So when that balance is disrupted and those protective factors can't overcome the pepsin, the gastric acid, the NSAIDs, the H. pylori, that's when we end up with ulcers. We have too much destruction going on, not enough protection going on. You know, everything you'll hear me say over and over again when we're thinking about treatments and diseases, we are constantly weighing the risk versus balance of everything as it relates to medicine. Right. So let's talk about H. pylori, which is Helicobacter pylori. This is a gram-negative bacteria. It produces urease, and the bacteria is typically found in the stomach or the duodenum. It can be transferred via the fecal-oral route, so similar to many of your hepatitis that you learned about. It's going to reside between the gastric mucus layer and the surface epithelial cells because it wants to be in a neutral pH. And so between the gastric mucus and the epithelial cells, the pH is neutral. It wants to stay in a neutral pH. So that's why it secretes the urease so that it can survive. So your stomach acid is acidic, and the H. pylori wants a neutral atmosphere, so they're going to secrete urease to neutralize that gastric acid so they can survive. H. pylori ulcers can be found, they're mostly found in the duodenal area. The pain is worse after eating. So you are fine, you eat something, and then you get pain is typically a sign that there is something going on in the duodenal. But eating foods or antacids can lessen the pain. So it's kind of a vicious cycle. You eat to decrease the pain, but then eating causes more pain there. H. pylori testing, we can use a breath. So here's one of our first clues of what might be on the exam. We can use a urea breath test. So we're going to test the breath for urea to see if there's urea, because again, that bacteria is spitting out urea into the stomach. And so if we're breathing out urea, then it tells us that there's something going on in our stomach, like H. pylori, that shouldn't be. We can also use a stool antigen test. For both of these tests, patients must be off all PPIs, bismuth, so Pepto-Bismol, and antibiotics for 2 weeks, or you'll get a negative result. So if you have a case that says this patient is currently on pantoprazole and we suspect H. pylori, we want to test for it. Can I use a urea breath test? No. Can I use a stool antigen test? No. I have to do a biopsy. All right, so, this patient was recently treated for H. pylori. When can we test for eradication? 2 weeks after they've stopped their antibiotics, PPIs, Pepto-Bismol. And this becomes important because PPIs and Pepto-Bismol can be given over the counter. So when we're getting ready to order these tests or recommend these tests, we need to make sure that the patients have been off those drugs. All right, so if the patient has not been off of those, then we need to use a biopsy urease testing. So where we go in and down the throat during an endoscopy, pull a piece of tissue and do the testing there. So our goals of therapy when we find H. pylori in a patient is we want to eliminate the bacteria. It's not supposed to be there. We want it out of there. Let's get rid of it. We want to relieve the ulcer pain and other symptoms. We want to reduce acid secretion because reducing acid secretion promotes epithelial healing, and then prevent ulcer-related complications like bleeding and recurrence. H. pylori is very tricky to treat. It requires 3 to 4 drug regimens. Our first line regimens for eradication are going to be bismuth quadruple therapies. So this would be we have a new drugs available. That would be Pylera plus a PPI twice a day. So we have bismuth subcitrate or subsalicylate plus tetranitazole plus metronidazole plus a PPI. We have clarithromycin triple therapy, which is our brand name of PrevPak. And you'll have PPI plus clarithromycin or an amoxicillin. If the patient has a penicillin allergy, we'll use metronidazole here instead of amoxicillin. But you see clarithromycin triple therapy has 3 agents, 1, 2, 3. You see bismuth quadruple has 4 agents, 1, 2, 3, 4. It's all in the name, people. And then we have concomitant therapy, which is a PPI plus clarithromycin plus amoxicillin plus metronidazole. So this is for drugs. So
Professor,
yes,
I'm sorry if I'm overstepping. I'm sorry that if you've already said this and I missed it. But can you tell us as we're going through and like trying to memorize this, what indicates us to pick which regimen if there's 3 good options?
we're gonna go over that in the next couple of slides.
Oops, sorry. Thank you.
Yep. So I'm not going to ask you about Pylera and PrevPak, but do recognize that many of the practice NAPLEX questions that I've seen do use Pylera and PrevPak in their questions. For the purposes of the exam, I will be using bismuth quadruple therapy, clarithromycin triple therapy, and concomitant. But do recognize in 2 years, you're going to have to know what's in a PrevPak and know what's in Pylera. All right. So going a little bit deeper into these therapies, first we have the bismuth quadruple therapy, and it is a PPI twice a day. This is really important. The PPI has to be twice a day in these therapy regimens. So when you're looking for an answer on a test about which regimen is most appropriate, make sure that the PPI is twice a day. We have to have sustained acid suppression so that we can kill the bacteria and heal the epithelial cells. And the only way to heal the epithelial cells is to increase the pH in the stomach, make it more basic. And the only way to do that is have sustained acid suppression. And the only way to do that is with a PPI twice a day. Right? It'll also have bismuth subcitrate in it or bismuth subsalicylate. So this is basically like Pepto-Bismol in tablet form. It'll have tetracycline and metronidazole. So how do we know if this is appropriate for our patient to use? This would be a good choice if our patients are at risk for clarithromycin. So if the clarithromycin resistance is greater than 15%, we would choose this. So, if I were writing on this slide, oops, but I can't right now because my screens are all messed up. So if the clarithromycin resistance is greater than 15%, we're going to choose this regimen, this bismuth quadruple regimen. Right? If the patient has a penicillin allergy, we can choose this because there's no penicillin in this. There's less drug interactions. And if we're buying all the agents individually, it is low cost, high value. Is what we say in the insurance world, but what I say in the real world is that it's cheap, affordable. Patients can get the medicine. All right. We're going to avoid this if patients are going to have a hard time with adherence because there's a high pill burden. There's 4 drugs taken 3 to 4 times a day. That can be really hard to adhere to. I don't know what our status is on tetracycline shortages, but historically we've had issues with tetracycline shortages. We can't use this if it's a pregnant person or a child. Why can't we use this in pregnant patients or children?
I think in children you're being careful about Rice syndrome.
That's a good guess, because it does have the subsalicylate in it. Thank you, Jose Yvonne. There's another, I mean, that is a good reason. That's not the first reason that came to my mind, but that's not a wrong reason. So tetracycline is a chelator that can bind to positive cations like calcium, right? And so if the patient is pregnant or if it is a child, they are still forming their bones and their teeth, and the tetracycline, what we're most worried about is it binding to the calcium that is forming the teeth and staining the teeth. You remember that from ID? Okay. Why would we not want to use this regimen in patients who have alcohol use disorder?
Because of risk of drug-induced injury,
With which drug?
tetracycline.
Okay. That's a good thought, but this is a 2-week course. Probably not an issue.
Isn't it something to do with the metronidazole? Like you're not supposed to have alcohol with that one.
Do you remember why you're not supposed to have alcohol with metronidazole?
I don't remember the term, no.
Yeah,
Okay.
due to the disulfiram reaction
Yes.
with alcohol.
Yeah.
Yes.
Yeah. So metronidazole has a structure that's very similar to one of the drugs that we use to help people abstain from alcohol. Use of alcohol and metronidazole can make people violently sick, like throwing up, nauseated. So if a patient has a alcohol use disorder or alcohol use abuse disorder, then we would want to avoid this for the risk of that. Funny enough, for as much as we counsel on that drug interaction, that drug interaction does not happen for every single person. I used to have friends in pharmacy school who would test out that drug interaction and come away unscathed. And then when you look at the data, which is why CRD is so important, if you want to know your risk of developing that reaction, should you need to be on metronidazole and not be able to drink because of a Christmas party or a concert or something, you would know that your risk of that drug interaction is really low, but it's so severe that we counsel every single person on it. That's just a little extra fun tidbit to tie in how important CRD is for managing your knowledge and your risks. All right. This is not FDA approved, but it has been shown to be as effective as triple therapy and concomitant therapy. So it is recommended in the guidelines as one of the first line agents. Right. We cannot, like, if there's a tetracycline shortage, we cannot substitute doxycycline. It has to be tetracycline, y'all. So we cannot substitute doxycycline. I'm trying. Doxycycline, I think, is the only other tetracycline that's coming to my brain right now. Oh, minocycline. We can't substitute minocycline. It has to be tetracycline. Okay, moving on to the clarithromycin triple regimen. Again, we see that PPI is twice daily. It does not matter what PPI it is. It can be pantoprazole, it can be omeprazole, it can be esomeprazole, it can be any of the PPIs, but it has to be twice daily. We have clarithromycin and amoxicillin. If they have a penicillin allergy, we can substitute the amoxicillin for metronidazole. One of the benefits of this is, it is simpler than other regimens. We only have 3 drugs and all of them are twice daily, except for the metronidazole, which would be 3 times a day, but all of them are twice daily. That's a pretty simple regimen compared to this previous regimen where it has something twice daily and everything else is 4 times daily. Right? So it's FDA approved, but we are seeing increased failure rates of the clarithromycin because of the increased risks of resistance to oh my gosh, macrolides. I was totally escaping my brain there. So we are seeing an increased risk of macrolides overall. So we're seeing an increased risk of resistance to clarithromycin. So if the resistance in the area is greater than 15%, we cannot use this this regimen. If the patient has had like azithromycin for an upper respiratory infection, we would not be able to use this regimen because they've had recent exposure to a macrolide that can increase the risk of resistance. So please pay attention here because in the patient cases, you're going to have to look for clarithromycin resistance. You're going to have to look for recent macrolide exposure. So you need to remember which antibiotics are macrolides. So clarithromycin is a macrolide, but we don't typically use that for treatment for anything. What are some other macrolides?
Azithromycin.
All right, y'all were paying attention to my azithromycin. What's another macrolide?
Erythromycin.
Erythromycin, great. I want you to think of clarithromycin as a dirty, dirty drug. Every time I see clarithromycin, I think drug interactions because it's a CYP3A4 inhibitor, and 3A4 are some of the is one of the most common pathways for drugs. So think about interactions with statins, blood pressure medicines. All right. It also can cause QTC prolongation. Also want to look at patients' allergy history to make sure that they don't have any allergies to macrolides. All right, next we have the concomitant regimen. This is the non-bismuth quadruple therapy. So we have 4 agents, but again, they're all twice daily. So even though there's 4 pills to take, that they're twice daily. So that could be helpful with adherence. Again, the PPI is twice daily, y'all. The PPI is twice daily. Okay, so what do you think about this particular regimen? What things do you think you have to think about when you're recommending it?
Penicillin allergy
Penicillin allergy? Great.
or
Clarithromycin.
I'm sorry, Kingsley, what were you saying?
I'm saying for the clarithromycin, you need to think about whether there's a previous use of a macrolide and also whether there is resistance above 15%.
Excellent. Excellent.
alcohol use.
Alcohol use, great. So all right, I see also, so clarithromycin, we have to be thinking about, oops. Resistance greater than 15%. We need to think about drug interactions. We need to think about recent macrolide. All right, QTC prolongation. For amoxicillin, we need to think about a penicillin allergy. And for metronidazole, we need to think about alcohol use. So see how it's really important to remember what happened in ID and how all these PTs are starting to build on each other. So it's not enough to say like, whoo, I just got through ID. I'm never going to see this stuff again. No, it's going to come back over and over. All right, so benefit of this therapy is that it's twice a day compared to the complex bismuth quadruple therapy, which was 4 times a day. But it may be more tolerable than the bismuth quadruple. Again, it may not be appropriate for patients with severe penicillin allergy because we have both the amoxicillin and the metronidazole in this regimen. Again, we want to avoid in patients with recent macrolide exposure and a resistance rate greater than 15%. Watch out for drug-drug interactions and QTC prolongation. This one is not as well studied as the other options. So I think of this as kind of like, even though it's in our lump of first line options, it's kind of our last first line option in my brain. Here, for completeness sake, are some other regimens that have been studied and approved and used. Please do not memorize these. Ideal regimens, that we are looking for are effective, well tolerated, easy to adhere to, and cost effective. The regimens need to include at least 2 to 3 antibiotics. These ones are not as well studied in the US and have more complex or more expensive regimens or regimens that have increased risk of resistance, like the ones with levofloxacin in there. So please don't worry about this slide. This is just a FYI. So write FYI on it and cross it out. Okay, again, we are not going to make drug substitutions in H. pylori eradication regimens. We should never substitute PPIs for H2RAs. And we should never substitute other antibiotics within a class. So again, it's going to be tetracycline. It's never going to be doxycycline. It's never going to be minocycline. It's always going to be clarithromycin. It's never going to be erythromycin or azithromycin. It's always going to be omeprazole, pantoprazole, esomeprazole. It's never going to be famotidine.
Why don't we substitute?
Because for the H2RAs do not cause the pH in the stomach to increase significantly enough, and they do not cover the full 24 hours. So we need that pH in the stomach to increase so that the epithelial layer can heal. The only way to effectively do that is with PPIs. And then with the antibiotics, the other antibiotics are not studied, and so we should not be using them.
So can we use other PPIs or just omeprazole?
You can use any PPI as long as it's twice a day.
That's interesting.
All right. So this is an important slide to remember these concepts. So how do we know if a patient is better? After 4 weeks of completing the antibiotic therapy, we are going to test for cure. We need to hold that PPI for 1 to 2 weeks prior to testing. Why do we need to hold that PPI before we test for cure?
False negative.
Yeah, it can give a false negative of which test?
The urea breath test. or stool test.
Yes, great. All right, so just a little cartoon of everything that we talked about here as it relates to H. pylori. We have the bacteria infecting us. It's a gram-negative rod that lives between the epithelial surface and the mucus. It releases urease to bring the pH of the stomach up so it can survive in that environment. So that urease, that ammonia is going to cause damage to the gastric mucosa, which can lead to ulcers. We typically treat, this would be our chlorothromycin triple therapy with omeprazole, chlorothromycin, and amoxicillin come to kill the bacteria, increase the pH of the stomach to promote healing. Okay, moving on to the next topic, NSAID-induced peptic ulcer disease. We talked about how NSAIDs increase the risk of peptic ulcers. So if patient is chronically using NSAIDs, about 15 to 30% of patients who chronically use NSAIDs will develop an ulcer. The ulcers in NSAID-induced peptic ulcer disease are more often in the stomach, in the gastric area, and about 2 to 4% of those ulcers will bleed. Right. This leads to 100,000 hospitalizations and about 7 to 10,000 deaths per year. And so ulcer-related complications are 3 to 10 times higher in patients who use NSAIDs than patients who do not use NSAIDs. So again, these NSAID-induced ulcers are going to be in the stomach area and the gastric area, and they're going to get worse with eating. So how do we get ulcers from NSAIDs? So we have the direct gastric mucosal damage and irritation from the NSAIDs sitting in the stomach, but we also have the systemic inhibition of COX-1. So if you remember from self-care, COX-1 is GI protective. It increases mucus production. If we inhibit COX-1, we're going to lead to decreased mucus production. We're going to have decreased bicarbonate secretion. We're going to have reduced mucosal blood flow and impaired platelet aggregation. All right, so you see COX-1 here and what the NSAID does to COX-1, and we end up getting mucosal injury and then increased risk of bleeding from all of that. So it's the inhibition of COX-1 that leads to the increased risk of ulcers in patients who are on NSAIDs. Important concept to know that it's not just the irritation that's happening from the drug in the stomach, that it is the inhibition of COX-1 that causes the damage, an increased risk of bleeding and ulcers for patients who are on NSAIDs. So when we're looking at patients on NSAIDs, we need to stratify their risk. And so patients who are at low risk are patients who have no risk factors and who are younger than 60. We don't really worry about these patients too much. It's the patients who are at moderate and high risk that we have to do something about when they're on an NSAID. So these are patients 60 to 65 years old. They have high dose NSAID therapy, or they're using things like aspirin, steroids, and anticoagulants with their NSAID. These people would be moderate risk. Patients with high risk would be people who have a history of peptic ulcer disease or patients who have more than 2 risk factors. So they're 65 years old and they're on high dose NSAID therapy, or they're 65 years old and they're on an anticoagulant for their atrial fibrillation. All right. So for patients who are moderate to high risk, we need to come up with a prevention plan. Because a lot of times we have to use NSAIDs. There's no good alternative. So if we have to use NSAIDs, we need to come up with a prevention plan. And so our strategies for preventing for patients that are moderate to high risk, obviously avoid NSAIDs. Again, not always possible. We want to use the lowest effective dose for the shortest duration. Again, that's nice in an ideal world, but what if somebody has chronic pain or a chronic condition that requires NSAIDs? So looking at the patients who require long-term NSAID or aspirin use, we want to consider adding a PPI on. A PPI can help increase the pH of the stomach to help repair any injury in the lining that is happening and also prevent any injury from happening. We can use misoprostol. So misoprostol we'll talk about tomorrow in Women's Health and its activity as it relates to medical abortions. But misoprostol is a GI protectant that we can combine with the NSAID to help produce or help to prevent GI peptic ulcers. The problem with misoprostol is that it can cause diarrhea, it can cause abdominal pain. We can't use it in pregnant patients or patients who are trying to get pregnant because it's abortifacient, and it can increase the risk of cardiovascular disease. But it is one option. You often see like Arthotec is a drug that's available that has diclofenac, which is an NSAID plus misoprostol in the same tablet. And then the other thing we can do is we can look for COX-2 selective NSAIDs, because remember, it's the inhibition of COX-1 that causes the problem. So if we can avoid inhibiting COX-1 and do more COX-2 selective, we can help decrease that risk. Not eliminate it, but decrease it. So celecoxib is a COX-2 inhibitor specifically, but we do have to be mindful that it has increased cardiovascular risk. Meloxicam is more COX-2 selective. That is really commonly used. It's a great drug. It's once a day, very low risk of overdosing or taking too much that you need. Nabudone is a drug not as common, but it is COX-2 selective. Diclofenac, like I said earlier, is often combined with misoprostol, is a COX-2 it prefers COX-2 over COX-1, and then etidolac is another COX-2 selective. All right, so if a patient is presented to you with moderate to high risk of an NSAID-induced ulcer, these are the things that you're going to look for in the answer choices to help prevent NSAID-induced ulcer. So what if nobody noticed the risk of the NSAID-induced ulcer, or despite everything, they developed an NSAID-induced ulcer anyways? What are we going to do to treat this? We're going to reduce the NSAID use. Duh, that makes sense. Like, get rid of the thing that's causing the problem. We're going to help them with smoking cessation, because that can increase the risk of ulcers. We're going to avoid alcohol, foods, and drinks that precipitate symptoms. Right? If it hurts, don't do it, type of thing. We're going to try to do a PPI before breakfast for a minimum of 8 weeks. So thinking about omeprazole, esomeprazole, pantoprazole, lansoprazole, etc. Why do we do it before breakfast?
Acidity.
I'm sorry, Christian, what was that?
Empty stomach for acidity, looking for acid environment.
Not quite.
It gets more absorbed when, when there's no food in your stomach, maybe?
So it doesn't have to do with the absorption.
Chelation?
I'm sorry, Ernesto?
Chelation?
I'm not sure if it's chelation, but PPIs are prodrugs that need to be activated in the liver. So they need to go through the stomach, be absorbed in the small intestines, be activated in the liver, and then be sent back through the bloodstream to the stomach to turn on active proton pumps. So they need to be taken before breakfast so that they can be absorbed and get to the liver and get activated, so that when the food hits the stomach, the drug is ready to come through the bloodstream and attack those active pumps. Right, do you remember Dr. Hong talking about this? The activation of these, they're prodrugs activated in the liver, come back to the stomach and the blood, and only turn off the pumps that are turned on. So we take them before breakfast because we want them to get through, absorbed through the bloodstream to liver activated, and be back in the stomach bloodstream by the time the food is there, so it can turn off the active pumps. H2RAs are not recommended, so your cimetidine, your famotidine are not recommended. They do not increase the pH of the stomach enough to provide the healing that is needed. So Sulcralfate can be used before meals. So Sulcralfate is becomes like a slurry sludge that puts a physical barrier over it's like painting over the ulcer so that you have decreased symptoms, but it's not doing anything to heal or help the ulcer. The Sulcralfate is only for symptoms. It's only to help you be able to eat. And it can cause constipation and binding with other drugs. Right? Any questions on that? We have to use PPIs for 8 weeks. We can use Sulcralfate before we eat something to help us, but the Sulcralfate is only for symptomatic relief. Right. I think this is a good time to take a break. We'll take a 5-minute break that puts us at like 12:27. Okay, we will go ahead and get started. Again, we'll finish this up here. So we are going to move on to stress-related mucosal damage. This would be our stress ulcers. All right. So, stress ulcer, how do stress ulcers occur? This is from metabolic stress, and it's usually experienced by a patient in the ICU. They have decreased blood flow to the gut because the blood is being diverted to the major organs of the body. So the blood is being sent to the brain, to the kidneys, and we don't really need our gut that much in an emergency, like when we're in the ICU. And so if we're not getting as much blood flow to the gut area, we're going to get a breakdown of the gastric mucosal defense mechanism. So we're going to get a breakdown of the prostaglandin synthesis, the bicarbonate production, and decrease in cell turnover. What we think is happening when patients have a stress ulcer, when they are in a critically ill situation, we think that they start getting mucosal ischemia. So the mucosa inside their stomach starts dying. It doesn't get enough oxygen, and when the mucosa doesn't get oxygen, it dies, and that leads to reduced gastric blood flow, resulting from splenic hypoperfusion. So we're not getting enough blood flow into our GI tract. All right. So here we have the critical illness. We can have shock or hypotension when we're critically ill. And we can have hypovolemia, not enough blood volume when we're critically ill. So that leads to decreased cardiac output. That decreased cardiac output leads to splenic, so that abdomen area, and mucosal hypoperfusion. So we're not sending blood to our stomach because it's not a critical organ at this time. So we get decreased bicarbonate secretion, decreased mucosal blood flow, decreased GI motility, decreased protective factors, and acid-backed diffusion, which leads to an acute stress ulcer. So based on randomized trials and guideline recommendations from the American Society of Health System Pharmacists, ASHP, stress ulcer prophylaxis should be administered to all critically ill patients who are at high risk for GI bleed. So how do we determine who is high risk? Patients who are high risk are critically ill, so they are in the ICU with one of the following. They've been on mechanical ventilation more than 48 hours. So mechanical ventilation is on a ventilator. The tube is down their throat and doing the breathing for them. Mechanical ventilation is not an oxygen in your nose, not a nasal cannula. It is a tube down your throat doing the breathing. All right, so let's be clear, because many of you have not stepped foot in a hospital or understand what the ICU is. Mechanical ventilation is them on a ventilator. The tube is down the throat doing the breathing for them. A nasal cannula is not mechanical ventilation.
Professor,
Yes.
sorry, is the mechanical ventilation a cause for the chest ulcer because it's when if it's a tube going down into the throat, I'm imagining that as it gets into that GI tract, it can cause abrasions and I'm going down the wrong track.
The tube doesn't go down that far. The tube goes down towards the lungs because your esophagus, like your tube has your larynx and your esophagus. So the tube goes into your larynx to inflate your lungs, not down into your esophagus, into your stomach. It's because if you have to be mechanically ventilated, your body is in a ridiculous amount of stress. And when your body's in a lot of stress, then we get to hypoperfusion of the GI tract. And hypoperfusion leads to all those issues, decreased bicarbonate, decreased blood flow, decreased protective factors, increased acid staying in the stomach. So when you have to be mechanically ventilated, you are very, very sick, and the oxygen is only going to your brain and your kidneys, maybe.
So the ventilation doesn't cause the stress ulcer per se, but if we are on if you are at that stage, we can already just knock out that you're under significant stress, and now we know probably that's gonna happen.
Yes.
Thank you.
Yep. The other the other criteria would be coagulopathy. So if the patient has an INR of greater than 1.5 and they're not on warfarin or any other drugs that can increase the INR, that tells us that if an INR is 1.5 without being on any drugs that cause an increase in INR, what does that tell us is going on with the patient?
Increased bleeding risk. I don't want to sound dumb.
Yep. So why do they have the increased bleeding risk if they're not on drugs that increase bleeding?
They maybe have liver dysfunction.
Yes, so remember that elevated INR and decreased platelet counts are symptoms of liver dysfunction. All right, so if they are telling us that our liver is not working, and so if our liver is not working, that's indicative of how sick we are, how stressed our body is. All right. So you will be given a patient on an exam and say, these are what the patient has going on. Does this patient need stress ulcer prophylaxis? And you need to look for mechanical ventilation greater than 48 hours, and you need to look for coagulopathy, which means INR greater than 1.5, platelet count less than 50,000. Right. Other risk factors that have been considered for stress ulcers is a history of a GI bleed or a GI ulcer within the last year. If you've had one, you're likely to be susceptible to that. Spinal cord injury, severe TBI, severe burns greater than 35% of the body, sepsis, high dose steroids, or acute renal failure. But the criteria with the most evidence is that they're critically ill with one of these. So this is what I want you to remember for the exam. So how do we prevent stress ulcers? So stress ulcer prophylaxis, here is where we can use H2RAs. So we can use famotidine or cimetidine, but as you might remember from self-care, We need to be mindful of patients who are elderly or have severe renal impairment because H2Rs can accumulate in these patients and cause delirium, dementia, cognitive impairment. And these patients are already in the ICU and at risk for those things anyways. So we typically don't see a lot of H2RAs used for stress ulcer prophylaxis because oftentimes these patients who are critically ill have renal dysfunction. Often these patients are elderly. And by being in the ICU, you're at increased risk of delirium. So adding this drug on would be another cause of delirium that would make things really, kind of foggy and difficult to see clearly. So oftentimes we'll see PPIs used for stress ulcer prophylaxis. When I was a student, we put everybody who walked in the door to the hospital on stress ulcer prophylaxis. And this is and this is one of my biggest pet peeves for patients in the community who are out or who are being discharged is, did they come in on the PPI? Do they need to still be on the PPI? How did they get put on the PPI? Evaluating whether somebody should be on a PPI or not is one of the number one things that pharmacists can do to get rid of medications that aren't needed. Because a lot of times they'll get put on in the hospital and patients won't even know why they're on them or why they're still on them. So we should always be critically looking at PPIs and whether the patient still needs them.
Professor?
Yes.
So if somebody has GERD, with it being like a chronic condition, and they're on PPI just as part of their medication regimen, just their normal medication, what is the benchmark for when they need to be reassessed or possibly taper down?
So I think if their symptoms are, if we're talking about GERD and trying to get a patient off PPI, I think if their symptoms have been controlled for a relatively decent amount of time, that we should consider having them take the medicine every other day and see what happens, and then every third day and see what happens, and every fourth day see what happens for like week increments to see if their symptoms come back or if their symptoms can be managed with Tums or H2 RAs. But that takes a lot of effort on the provider's part and the patient's part. But I wouldn't stop PPIs cold turkey because you can have rebound acid production, which then makes patients think that they really do need it. You need to slowly taper them off. So decreasing to the lowest possible dose and then trying that every other day, every third day, every fourth day, taper off. All right, so what happens if that peptic ulcer starts bleeding? We're going to see hematoedemesis. We're going to see potentially melena, which is dark tarry stools or blood in the stools. And we could see an acute drop in hemoglobin or hematocrit. That would be like your hemoglobin dropping greater than 1 point. Hematocrit, I can't remember what like the cutoff is, but I'm constantly monitoring hemoglobin in my patients who are in the hospital and looking for greater than 1 point drops to see if they're bleeding from anywhere. Excuse me. So if a patient develops that peptic ulcer bleeding, so they are coughing up blood, they are throwing up dark coffee ground emesis, they are have dark tarry stools. They're probably not going to have bright red and blood in their rectum unless they are having a lot of diarrhea, because if the peptic ulcer is bleeding, it's bleeding high in the GI tract, and that blood is going to oxidize as it moves through the GI tract and become that dark tarry brown color. But because if they're bleeding a lot, blood is an irritant that can cause diarrhea. So they might have bright red blood in their stools, but mostly it's going to be dark tarry stools or throwing up that. So if a patient is bleeding, we want to make sure that we're correcting their fluid and volume loss. So we want to make sure that we're giving them normal saline and giving them blood so that their hemoglobin is greater than 7, between 7 to 8. Some patients who have other chronic disease, that goal might be different, but just in general, we're looking for a hemoglobin goal of 7 to 8. We want to do that camera down the throat, that diagnostic EGD as soon as possible, because we might have to cauterize, do ablation on the areas. But the thing that we as pharmacists do, we want to talk about high dose proton pump therapy. We want to get that gastric pH up to 6 as soon as possible. That gastric pH of 6 helps promote hemostasis, so it helps decrease the bleeding, and it helps form a clot so that the bleeding stops, and it reduces the risk of rebleeding. So how do we do that? We're going to use an IV bolus of pantoprazole or esomeprazole, and then we're going to do a continuous infusion for 72 hours. All right. And the reason we do the IV bolus and the continuous infusion is because we avoid that having to be absorbed, going and being activated and turning off the activated pumps. We get those pumps to turn off a lot faster with that IV bolus and that continuous infusion. As soon as we get those pumps down, that pH in the stomach rises, we get stability so that those clots can form and the bleeding stops. When the person has the EGD, and if there's no active bleed, we're going to stop that IV medicine, because the IV medicine is more expensive to obtain and more expensive to administer, because think about all the nursing requirements of running an IV bolus and a continuous infusion versus just giving a tablet. So one of the number one things, in the hospital that when I'm on the team, I'm looking for is, you had an EGD, there was no active bleed, let's switch this IV PPI to oral. All right. There are some places that are doing IV push, but I cannot find the evidence for it. I haven't looked in maybe a year or so, but I can't find the evidence for IV push. The NAPLEX book and the guidelines that I find still recommend the IV bolus plus the continuous infusion. After that 72 hours, you can switch to oral, because your proton pumps are adequately turned off and your oral one will be given time to work. Also, the risk of rebleeding is highest within 72 hours. So once we get past that 72 hours, we're really in a much better spot. So we talked about this a little bit in self-care, but going to focus a little bit more on this. Warnings for acid suppression medications. So some of our drugs require an acidic environment for absorption. So if we are decreasing the acid in the stomach, increasing the pH of the stomach, we don't have that acidic environment for those drugs to be absorbed. And so we need to be mindful of drugs that are enteric-coated or delayed release, because those are designed to be released in a more basic environment. So they could be prematurely released in the stomach instead of the duodenum, which could lead to the breakdown of those drugs, make them not as useful. All right. One of the other things to think about is the long-term risks of PPIs. And this is why I think it's really important for us to ask, why are you on a PPI whenever we see a patient? Do you still need the PPI? So patients who use long-term PPIs are at increased risk of C. difficile, right? Code Brown is what we like to call it in the hospital. Really bad diarrhea that can be very dangerous. They're at increased risk of pneumonia, because the acid reflux, if you're supposed to have a little bit of a reflux, acid reflux. Everybody's supposed to have a little bit of acid reflux, because that prevents any bacteria from that could be hanging out in our esophagus from getting down into our larynx and into our lungs. If we suppress all the acid reflux and there's no acid reflux, that bacteria that's hanging out in our esophagus can get down into our larynx and cause pneumonia. So acid reflux is protective. There is a reason for it, but if we shut it down long term, we can end up with pneumonia. All right. calcium is something that needs an acidic environment for absorption. So if we are on long-term PPIs and we have an elevated pH in the stomach, we're not absorbing our calcium as well. And that if we don't absorb our calcium very well, that can lead to increased risk of bone fracture, so osteoporosis. And osteoporosis can lead to bone fractures. So for patients who are on PPIs, we want to use something like calcium citrate because it doesn't require an acidic environment to be absorbed, but calcium carbonate, which is the most ubiquitous calcium supplement out there, does require an acidic environment. So thinking about when a patient comes in and says, oh, I need calcium, you know, think about your postmenopausal woman who comes in is like, oh, I need calcium for my bones. Well, postmenopausal, they're older, they're going to have less acid in their stomach anyways. If they're on a PPI, they really don't have any acid. So we're going to want to point them to the calcium citrate, the Citracal, not the calcium carbonate, not the chocolate chews. All right. Long-term risk of PPIs also include low magnesium. So we're not absorbing our magnesium as much. And so we can have low magnesium, which can affect our heart. And then we do need to think about omeprazole and esomeprazole because those are 2C19 inhibitors, and those decrease the effectiveness of clopidogrel, which could lead a patient to have a stroke or a heart attack. So my favorite PPI to use is pantoprazole. It's not a 2C19 inhibitor. It's available generic, very easy to use. We do have a new drug that is out on the market, and it is vonoprazan. And this is going to, like, as soon as the price point becomes something that's comparable to PPIs, I think this drug is really going to take off. It is a potassium competitive acid blocker, so it suppresses acid by blocking potassium from binding to the hydrogen potassium ATPase. It's getting more and more FDA approved indications in adults. So it helps with healing and maintenance of erosive esophagitis. It helps with the treatment of H. pylori infections when it's part of the triple therapy or dual therapy. And it can help with relief of heartburn associated with non-erosive GERD. So those are the FDA approved indications right now. It overcomes the limitations of the PPI. So PPIs have a short half-life, so they don't provide a full 24-hour reduction of acid. So that's why this drug can be, is potentially going to be better than PPIs. It starts working right away, where with PPIs, it takes about 3 to 5 days to see the full effect and get all those pumps shut off. Because this drug works by working on all the pumps, not just the active pumps, where the PPIs have to have an active pump. And then there's, you know, potential reduction, those 2C19 drug interactions that are with PPIs. There's likely not any of those with this vonoprazan. It's been approved, I think Dr. Hong told me it has been approved in the like Japan and China for quite a while compared to the US. This just became approved in the US like in 2022 or 2023. It's really shaking up our managed care world at the insurance company because it is more expensive, but it's also more effective. Right now, I think the place is in therapy is for people who have failed PPI treatment, because you have to go with PPIs are going to work for most people. And so I think that if they fail PPIs, this would be the next step for those patients. But interesting to watch and see. Right, so this is just a summary slide of our characteristics of peptic ulcer disease. So if we have an H. pylori infection, it's a chronic infection. The damage is usually in the duodenum versus the stomach. It's most dependent on the intragastric pH. It usually has epigastric pain relieved by eating or taking antacids. The H. pylori doesn't typically cause a GI bleed. If it does, it's one vessel. NSAID induced is chronic. It's usually in the stomach more than in the duodenum. It's not dependent on gastric pH. Most of the time, patients are asymptomatic and pain can worsen with eating. The ulcer is very deep. And so because the ulcer is very deep, we see multiple risks of bleeding because the ulcer is deep. All right. So we have more severe bleeding, also a single vessel. Stress-related mucosal damage we see is acute. This is psychological stress and physical stress, metabolic stress to a body. All right. And then those happen mostly in the stomach. They're not dependent on pH. Patients are usually asymptomatic because they're very sick. They're usually superficial, but we will see more severe bleeding because it's over a larger area. Okay. All right, so when you're thinking about studying for this, this would be a good slide to study and see if you can answer like the H. pylori, when we do testing, what testing we do, what testing is limited by, which drugs, how we treat it, what treatment considerations. For NSAID-induced ulcers, thinking about the mechanism of how NSAIDs cause an ulcer, what risk factors are important. Prevention of NSAID-induced ulcers and treatment of NSAID-induced ulcers, and then thinking about stress ulcers and risk factors. So thinking about that mechanical ventilation and coagulopathy, and what does that mean, and how we're going to prevent that. And then if the patient gets to an active GI bleed, what treatments are we going to use? What questions do you have on peptic ulcer disease?
Just for my clarification, Dr. Hall, apart from stress and H. pylori, would there be any other cause of peptic ulcer disease?
Besides H. pylori, NSAIDs, and stress, there are other, like you can have cancers that can cause peptic ulcers. So that's why we need to do an endoscopy to see. So there are other causes, but not other causes that aren't directly related to things that pharmacists can do with medications. So there are cancers that can cause peptic ulcer disease. Alcohol can as well.
When there is a direct injury to the stomach, for instance, I know of a patient who ate a lot of pepper, very spicy meat and whatever, and eventually they said the patient came up with an ulcer, but there was no H. pylori when they did the test for that patient. What would this be classified as?
I am not sure because I don't have enough information to classify that. I know that drugs can irritate ulcers. I don't know, or not drugs, foods can irritate ulcers and irritate symptoms, but I don't know if they, like how much foods and if there is a certain amount that can cause an ulcer. That's beyond the scope of my knowledge is of how foods. There could be people that are just predisposed to it because there are people who don't have cancer but have risk factors for cancer that again beyond the scope of what a general pharmacist needs in this lecture.
Thank you.
I'm going to go ahead and start the IBS lecture because we have time and I want to make sure that we're not rushed tomorrow. So since I'm here and I have it ready, we're just gonna go ahead and get started with that. So the IBS slides should be on Bright's put them on there sometime last week. Please let me know if you can't see them or don't have them. I'll give you a second to get them pulled up here.
I can see it.
You can't or you can?
I can't.
You can't? Thank you for letting me know. Let me double check. I'll just, instead of looking, it seems that some people can see it, some people can't. I'm going to go ahead and just put it in the chat. Oops. Okay. All right, so irritable bowel syndrome, this is the clinical aspect. Dr. Hong will come in tomorrow. Tomorrow's lecture will be in person. I will be streaming in to the lecture hall, but Dr. Hong will be lecturing. So it'll be a hybrid lecture, but you will all be in person tomorrow. Right. So objectives, again, describe what's happening that contributes to IBS and identify the types of IBS, identify non-pharmacological treatments and their place. And then when you're given a patient with IBS, figure out which drug we should use based on the mechanism, patient-specific factors, the type of IBS. All right. So what is IBS? IBS is the most commonly diagnosed GI condition. It affects females more than males. And it accounts for 25 to 50% of referrals to gastroenterologists. Remember, IBS is mostly a diagnosis of exclusion. We've ruled out that you don't have Crohn's, you don't have ulcerative colitis, you don't have, anything that we can think of that is causing this. You're having these symptoms and we don't know why. Is basically what IBS comes down to. There's no test to say, yes, this is IBS. It's like everything else has come back negative. This is IBS. And it affects females more than males, and we can talk about that more, in the context of what we've learned about endometriosis and PCOS for patients, and other diagnoses that are often diagnoses of exclusion and providers just not believing female patients. But that's, a topic for women's health and not here, but something to think about as all our courses are interconnected. IBS presents with chronic abdominal pain, altered bowel habits, and again, the absence of any organic cause. You don't have C. diff, you don't have ulcerative colitis, you don't have Crohn's, you don't have norovirus. We can't find a reason for your diarrhea or your constipation or your abdominal pain. So things that are thought to because we don't know what causes IBS, we think about a lot of factors that can contribute to that. We see things like genetics playing a role. So if a family member has it, you're more likely to have it. We see some issues with motility factors. So altered somatovisceral and motor dysfunction in the intestines that can lead to how fast or slow the stool is traveling through the GI tract. We can see issues with abnormal CNS processing. So how we are processing the signals that can lead to, from the gut, that can lead to hypersensitivity. So we're getting an increased sensation in response to a stimuli that is coming through as pain. We can have inflammation. We can have colonic infections that might tip us over to like never fully, if we have C. diff, our bowels might never fully recover and lead to IBS. And then stress. Like everybody wants to say stress is the #1 cause of IBS. So as somebody who had to have a full workup for some abdominal pain when I was 18, I mean, in the end, it ended up being a kidney issue, but I was told that it was cyst on my ovaries. I was told that it was IBS. I was told that it was a lot of things until they finally did imaging and saw that it was a structural issue with my kidney. So I think in my experience as a patient and what I see from other patients is we often blame stress for a lot of ailments, especially in female patients. I think Dr. Hong talked about the activity of 5-HT or serotonin in the GI tract when we talked about constipation and diarrhea and drugs last semester in self-care. We're going to talk more about the serotonin and the impact of that on the gut in IBS. A lot of our enteric nervous system contains a lot of serotonin receptors. So we have serotonin type 3 receptors and serotonin type 4 receptors, and a lot of them are, the majority of them, in our gut. And this is probably where the phrase brain-gut connection comes in, and because serotonin is not just associated with our mental health functions, but it's also associated with our gut function. So the brain-gut connection is saying if our mental health is not well, our gut is not going to be well, and kind of vice versa. These serotonin receptors are responsible for secretion, sensitization, and motility of the GI tract. The increase of postprandial levels of serotonin in the GI tract. If a patient is suffering from diarrhea predominant IBS, we will note increased levels of serotonin in the GI tract after eating. So we do think that their serotonin does play a role in IBS because, again, in those patients who have diarrhea predominant, we do see more serotonin in their gut after they eat. So we think serotonin has something to do with it. So what do these patients complain about when they're talking about, they're diagnosed with IBS? So they have lower abdominal pain. They have abdominal bloating and distension. They can have diarrhea symptoms and diarrhea is defined as more than 3 stools a day, all right? Because it's important how we define things. When we're talking about IBS, diarrhea is defined as greater than 3 stools per day. Sometimes these patients will have extreme urgency. Sometimes they will have mucus in their stools. Constipation is defined as less than 3 stools per week. That also has straining and incomplete evacuation. So to make that, for the purposes of IBS diarrhea is greater than 3 stools per day. IBS constipation is less than 3 stools per week. This way we're all talking the same language. Often these symptoms will lead to things like depression and anxiety because it can be really frustrated to have diarrhea, have loose stools more than 3 times a day. That significantly impacts your life, as well as constipation, where you're having to strain or have an incomplete evacuation every time you have to have a bowel movement. So to classify IBS, because IBS can mean just abdominal pain, it can mean constipation, it can mean diarrhea, it can be mixed. So how do we classify this? We have IBS-C, which is IBS with constipation. And this is where we have hard or lumpy stool 25% or more of the time. We have IBS-D, or IBS with diarrhea. So this is loose or watery stool 25% or more of the time. We have IBS, mixed IBS or IBS-M. And that's where you have hard lumpy stool for 25% of the time, and the other 25% of the time or more you have watery stool. This becomes the most tricky to treat, right? Because at least a quarter of the time you're constipated, at least a quarter of the time you're having diarrhea, and the medications to treat those are in complete opposition, right? And then we have IBS unclassified, which doesn't meet any of the criteria above. So if you see a case in your exam or your cases on Thursday, you're going to see IBS-C. That means that the patient is constipation predominant. You're going to see IBS-D, which means the patient is diarrhea predominant. It's important to know that these subtypes people can switch, like that you can start out as IBS-C and then you can switch to IBS-D. These classifications are fluid, so we always have to be asking the patient about their bowel movements, because 75% of patients will switch subtypes within a year. So bringing back the Bristol stool scale so that we're all talking about the same thing when we're talking about diarrhea and constipation. 1 and 2 are associated with constipation. So if the patient is talking about separate hard lumps like nuts that are difficult to pass, or a sausage-shaped lumpy stool, that is constipation. If they're talking about fluffy pieces with ragged edges and a mushy stool, and watery with no solid pieces, this is associated with diarrhea. Remember, this has to be greater than, so greater than 3 times a day. And this is less than 3 times a week. Right. Any questions on classifying the IBS? So this is just another visual for us for the subtypes and what it's going to look like for patients. Again, that type 1 and 2 is the constipation, that 6 and 7 is the diarrhea. So patients with IBS constipation are going to have these types of stools more than 25% of the time. Patients with IBS diarrhea are going to have these types of stools more than 25% of the time. And patients with IBS mixed are going to have equal amounts of constipation and equal amounts of diarrhea. So this is just kind of graphing it out where each of them lie. So our goals of therapy are to reduce, we're going to focus on the primary complaint. So if the primary complaint is abdominal pain, we're going to pick drugs that attack abdominal pain. If the primary complaint is diarrhea, we're going to pick drugs that go towards the diarrhea or treat the diarrhea. And if we have constipation as our primary complaint, we're going to pick drugs that treat the constipation, right? Like that, this makes sense. And hopefully by doing that, we're going to improve the quality of life for these patients. So our approach to treatment, our number one thing we need to do is identify the patient's concerns and main symptoms. So, I ask the patient, like, what is bothering you the most? What symptoms do you want to have relieved? And that's going to help me determine which medications to use. We can talk to them about dietary changes. We can talk about them about exercise, because exercise is really important for bowel health, especially if we're dealing with constipation. Because of the suspected brain gut connection with this disorder, we can talk to them about psychotherapy. And then, lastly, we're going to talk about pharmacological treatment. Sex assigned at birth is going to be very pertinent for proper medication decision making in this disease state, because there are many medicines that are only FDA approved for females. So patients who are assigned female at birth. So we're going to be, paying close attention to that in this particular section. So non-pharmacological treatments, we're going to identify and avoid triggers. So if a food triggers it, try not to eat it or try to limit your eating of it. If medications we're going to look to see if there's medications triggering the issue, and if we can change them or adjust them in a way that the medications are not becoming a trigger. And then hopefully helping to manage stress if stress is a trigger. For dietary, we're going to go back to self-care and think about all the things that we talked about for diarrhea and constipation there. Are they getting adequate fluid to ensure that they have adequate water available for their stool? Limiting caffeine and alcohol, making sure that we have soluble fiber available. So methylcellulose, psyllium, our fiber supplements if patients are not eating enough fiber. We're going to think about elimination diets. So, is somebody have a gluten sensitivity? Do they need to try gluten-free and see if that improves their symptoms? Right. This is something this chart you should be aware of, especially the ones that are highlighted in red. So drugs that cause constipation are anticholinergic drugs. So any drug we say is anticholinergic means can't see, can't pee, can't spit, right? So it's going to cause constipation because anticholinergics dry you out all over. Anticonvulsants can cause constipation. Anything that we use to treat diarrhea can cause constipation. So loperamide, we learned about that last semester being a treatment for diarrhea. It can cause constipation. It makes sense. Antihistamines. So antihistamines fall in our anticholinergic. So your diphenhydramine, it can, can't see, can't pee, can't spit, can't. All right. Anti-Parkinson's agents. Non-dihydropyridine calcium channel blockers, so your verapamil and diltiazem can increase your risk of constipation. Calcium supplements can increase your risk of constipation. Iron supplements, you learned about iron causing constipation, hard stools last semester. Opioids, you learned about opioids causing constipation. And tricyclic antidepressants. And this would be things like your amitriptyline would be probably the most common. I'm not sure if that's on your top 200 drugs, but I think it would be on there, amitriptyline. And we're going to talk more about these tricyclic antidepressants because these are some of the drugs that we can use for treatment of this disease. So we do need to be mindful of that. Tricyclic antidepressants are anticholinergics. Can't see, can't pee, can't spit, can't, right? Now, flipping the coin over to diarrhea, drugs that cause diarrhea are magnesium-containing antacids. We talked about this with our milk of mag when we're talking about treating GERD, right? Antibiotics can cause diarrhea because they alter the bacteria in the GI tract and disrupt that, can cause diarrhea. Chemotherapeutic agents, cholinergic agents. If anticholinergic causes constipation, cholinergic drugs cause diarrhea. Colchicine is a drug that we use for gout. That is one of the #1 drug causes of diarrhea. We actually can't use very much colchicine because of the risk of diarrhea. Colchicine is dosed based on whether the patient is tolerating it with diarrhea or not. Digoxin. Obviously, laxatives, polyethylene glycol, milk of magnesium. I'm trying to think of mag citrate, right? All those things that we talked about as laxatives last semester can cause diarrhea. Metformin is a drug, it should be in your top 200 that is used for diabetes. And the number one reason people can't tolerate it is because of the diarrhea. It prevents the absorption of sugar as one of its mechanisms. If we don't absorb sugar, it has to go somewhere. It's going to leave the body as an osmotic laxative, diarrhea. Orlistat is a drug that prevents the absorption of fat. If we're not absorbing fat, it has to go somewhere. If it's just going to leave the colon as greasy, oily stools. And then proton pump inhibitors can cause diarrhea, especially if they cause C. difficile. Okay, so please make sure you're familiar with this chart, especially the ones that are red, so that you can identify any triggers in a patient case for drug-induced IBS. All right, we will stop there and we'll start with IBS-C tomorrow. What questions do you have for me? All right, in person tomorrow so that Dr. Hong is not alone in the auditorium, y'all. Got it, got it? All right. Thank you for your attention. I will see you tomorrow.
Thank you.
Thank you.
How much lectures we're gonna have on the 6M?